Right now, over 150 million people worldwide take a daily pill derived from a medieval weed.
Yeah, it's a staggering number.
It really is. And, it has been saving lives for roughly 70 years now. Yet, if you ask the world's top pharmacologists exactly where in the body it works, they'll actually start arguing.
Oh, absolutely. The debate is surprisingly heated.
Welcome to the deep dive. Today's mission is to unpack a single globally essential drug for you, and that is metformin. We are going to figure out how it functions, why it almost didn't make it to your pharmacy, and how it is actively rewriting the rules of modern medicine.
So just to set the stage for you here, metformin is an oral anti-hyperglycemic drug. It's a biguanide, and it serves as the undisputed first-line pharmacological treatment for type 2 diabetes.
Right, the absolute gold standard.
Exactly. But what makes this compound so compelling is how radically its textbook definition has shifted over the decades. I mean, in the 1950s and 60s, it was understood very narrowly.
Like just as a simple glucose-lowering pill, right?
Yeah. Strictly for diabetics who still produce their own insulin. But by the 1990s, the medical community completely redefined it as a cardioprotective agent.
Which was a massive shift.
Huge. And today, the definition is expanding again. Researchers are now investigating it as a potential geroprotective or anti-aging compound.
Okay, let's unpack this, because before we can understand how this drug intercepts metabolic disease or, how it might literally slow down biological aging, we really have to look at its origin.
Right, the history is wild.
It doesn't start in a mid-century chemistry lab. It starts with a plant called Galega officinalis, which is commonly known as French lilac or goat's rue.
Yep, a simple hedgerow plant.
European herbalists were using this centuries before anyone had even mapped out the cellular mechanics of diabetes.
They were basically treating a symptom without really understanding the underlying pathology. So one of the primary uses of French lilac was actually to treat excessive urination.
Oh, wow. Okay.
Yeah, because in an uncontrolled diabetic state, the blood is just so saturated with glucose that the kidneys, well, they can't reabsorb it all.
So the body just hits the panic button.
Exactly. The body attempts to forcefully flush that excess sugar out through the urine, and it draws massive amounts of water with it. Herbalists noticed the plant mitigated this severe polyuria.
So they were effectively treating a hallmark of diabetes without knowing what diabetes really was.
Exactly.
And eventually, like in the early 20th century, chemists isolated the active constituent. It was a guanidine derivative they named galagine.
Right, which kicked off a massive race to synthesize related compounds.
Yeah, leading two scientists, Emil Werner and James Bell, to synthesize metformin, or dimethylbiguanide, back in 1922.
Yeah.
But then they essentially just shelved it.
Well, yeah. Guanidine compounds had a pretty troubled reputation due to their toxicity at high doses. But more importantly, metformin was eclipsed by a monumental medical breakthrough in 1921.
Oh, the discovery of insulin.
Right. Insulin was just such a miraculous, immediate lifesaver for type 1 diabetics that it dominated the entire landscape of diabetes research.
It just stole the spotlight completely.
It did. Oral compounds like metformin were completely ignored for decades. It wasn't until a French diabetologist named Jean Stern resurrected the clinical research in 1957.
Stern actually published the first clinical studies of metformin in diabetic patients, right? Like he gave it the trade name glucophage, which literally translates to glucose eater.
Yeah, very kitschy marketing for the time.
And he argued it was incredibly safe. But looking at the timeline of its rollout, it's just staggering. So metformin reaches the UK in 1958. It hits Canada in 1972.
But the U.S. is completely left behind.
Yes. An American patient couldn't get a prescription until the FDA finally approved it in 1994. It hit pharmacies in 1995. That is a 38-year delay, effectively denying a whole generation a life-saving intervention.
Yeah, that delay was the fallout of a massive public health disaster involving metformin's chemical cousin, which is called fenformin.
Ah, right, fenformin.
Fenformin was brought to the U.S. market much earlier, but it carried a severe risk of a complication called lactic acidosis.
Which is really dangerous, right?
Incredibly dangerous. Lactate is a normal byproduct of cellular metabolism, sure, but if it builds up too quickly in the blood, it drops the blood's pH to dangerously acidic levels.
Just toxifies the whole system.
Right, it shuts down normal cellular function, and it can be fatal. In 1977, after being linked to thousands of these fatal lactic acidosis cases, the FDA pulled fenformin entirely.
Just wiped it off the market.
Yep. And regulators were so scarred by that event, they treated the entire biguanide class with deep, deep suspicion.
It's like having a reckless sibling who just ruins the family reputation for decades.
Hmm.
You're perfectly well-behaved, but you can't get a job in town because everyone remembers what your brother did in 1977.
That is a perfect analogy.
But the irony of that guilt by association is that the difference between fenformin and metformin basically comes down to a tiny divergence in how the body processes them.
Yeah, the pharmacokinetics are entirely different. Fenformin relied on liver enzymes for its metabolism, specifically an enzyme called CYP2D6.
Okay, the liver enzymes.
Right, and liver metabolism can be highly unpredictable across a population. You have certain individuals who are genetic poor metabolizers.
Meaning their bodies just don't clear it fast enough.
Exactly. In those patients, the enzyme processes the drug way too slowly, causing fenformin to suddenly spike to toxic levels in the blood, which then triggered that fatal lactate buildup.
But metformin circumvents the liver's metabolism entirely, doesn't it?
It does. It is excreted perfectly unchanged by the kidneys. It enters the body as metformin, and it leaves the body as metformin.
Oh, wow. So it's totally stable.
Its clearance is highly predictable. But because regulators group the two drugs together based on chemical structure, rather than their metabolic pathway, American patients missed out on a profoundly safe and effective tool.
That is just tragic. So now that we understand how it survived that scandal, we really need to look at what it actually does once it gets inside the body.
Right, the mechanism of action.
Yeah, and to grasp the mechanism, we first have to look at the core defect in type 2 diabetes,
Yeah.
which is, surprisingly, fundamentally a problem with the liver.
Yeah, the liver essentially acts as the body's energy warehouse. In a healthy system, when you eat, insulin signals the liver to stop producing glucose and to start storing it.
It's like, we have food now, stop making emergency supplies.
Exactly. But in type 2 diabetes, severe insulin resistance means that signal is just ignored. So even when a person is fasting, say it's 3 in the morning, their liver behaves as if the body is actively starving.
So it starts churning out more sugar.
It continuously converts stored substrates into new glucose, a process called gluconeogenesis, and dumps it directly into the bloodstream.
The liver's natural brakes are just completely broken.
Yeah.
And this is where metformin intervenes, right? It steps firmly on that glucose production brake.
It does, and the pharmacology here is just fascinating.
Let's get into it.
Okay, so instead of thinking of mitochondria just as static cellular power generators, think of them as an engine with a very specific throttle. That throttle is called complex I of the electron transport chain.
Complex I.
Metformin acts like a governor on that throttle. It slightly restricts the energy output.
And that restriction causes a tiny but critical drop in the cell's energy currency, right? Which is ATP relative to its depleted precursor, AMP.
You've got it. The cell's sensors immediately detect this drop in the ATP to AMP ratio. This shift triggers a cellular panic button, activating a highly conserved energy-sensing enzyme called AMPK.
So if I'm understanding this sequence right,
Yeah.
if the liver is a runaway factory churning out unwanted glucose, metformin isn't out in the bloodstream sweeping up the excess product on the conveyor belt.
No, not at all.
Metformin is the factory manager yanking the emergency stop cord via AMPK.
That is exactly it. The activation of AMPK immediately halts the energy-intensive machinery of gluconeogenesis. The liver just stops dumping glucose.
Fantastic.
But AMPK's role extends even further. It fundamentally shifts the cell's metabolic priorities. It turns off fat synthesis and turns on fat oxidation.
It forces the cell to burn fat.
Right, it forces the cell to start burning fat for energy to compensate for the perceived energy deficit.
Which perfectly explains why metformin, unlike older diabetes medications, doesn't cause weight gain. I mean, if we look at insulin secretagogues, like sulfonylureas, those drugs just brutally force the pancreas to squeeze out more insulin to deal with the high blood sugar.
Yeah, those older drugs are really just managing the symptom, which is the hyperglycemia, by flooding the system with insulin. And insulin inherently promotes fat storage and weight gain.
But metformin works upstream.
Precisely. By addressing the liver's inappropriate glucose production, it is weight neutral, and it frequently induces modest weight loss, which is, highly beneficial for a type 2 diabetic demographic.
Understanding the liver mechanism is great biochemistry, obviously. But we both know chemistry alone doesn't change global prescribing guidelines.
Oh, definitely not. You need clinical trials.
Right. And the massive shift in how modern medicine viewed this drug came from the UK Prospective Diabetes Study, the UKPDS, which was published in 1998.
The UKPDS was an absolute watershed moment. It assigned overweight, newly diagnosed type 2 diabetics to either intensive metformin therapy or just conventional dietary treatment.
And the results were kind of shocking, right?
The data revealed that metformin reduced diabetes-related deaths by roughly 40%, and it reduced heart attacks by a similar margin.
A 40% reduction in mortality. I mean, that proves the drug was cardioprotective, completely independent of just lowering glucose.
Right, because the patients on sulfonylureas in the study, they achieved similar blood sugar reductions, but they didn't get that massive cardiovascular shield.
That is wild.
That single data point transformed metformin from just another glucose-lowering option into the mandatory first-line therapy. It basically proved that repairing the underlying metabolic signaling offered systemic protection that merely forcing insulin secretion just could not match.
And then the medical community pushed the boundary even further with the Diabetes Prevention Program trial, or the DPP, in 2002.
Right. They shifted focus from full-blown diabetics to patients with prediabetes or impaired glucose tolerance.
So catching it earlier.
Exactly. They tested intensive lifestyle change like strict diet and exercise against a metformin regimen.
Okay, and how did that pan out?
The intensive lifestyle intervention reduced the progression to full type 2 diabetes by 58% over 3 years. The metformin arm saw a reduction of 31%.
Okay, I have to push back a little on how this was interpreted clinically.
Sure, okay.
Because the data clearly shows that diet and exercise absolutely trounced the pill. I mean, it was almost twice as effective. Yet this exact trial made metformin wildly popular for off-label prediabetes use.
It did.
Why the massive enthusiasm for the drug if lifestyle interventions were the definitive, clear winner?
Well, we have to balance clinical ideals with public health reality, right? Lifestyle modification remains the absolute gold standard. But sustaining strict diet and rigorous exercise over decades is remarkably difficult for a massive segment of the population.
Yet behavior change is notoriously hard.
It is. So, a 31% reduction from a single, highly tolerated, inexpensive pill represents a massive systemic victory. Furthermore, the data revealed metformin was particularly effective in younger, more obese pre-diabetics.
Oh, interesting.
Yeah, it gave physicians a practical, actionable tool to delay a looming metabolic crisis when lifestyle changes inevitably faltered.
Okay, having a powerful safety net makes complete sense when you put it like that.
Yeah.
Now, because this drug is prescribed to hundreds of millions of people, it has accumulated a massive mountain of mythology.
So many myths.
So looking through the historical labeling and patient concerns, I really want to clear the air on a few major points for you. Let's start with the fear of hypoglycemia, or dangerously low blood sugar.
This is a big one. The assumption is that any diabetes drug will aggressively drive down blood sugar to the point of a crash.
Which is terrifying for patients.
It is, but as a monotherapy, meaning taken entirely on its own, metformin essentially never causes hypoglycemia.
Never.
Basically never. Going back to your factory manager analogy, metformin only suppresses the excess glucose production. It doesn't force the pancreas to indiscriminately pump out insulin.
Ah, right. It just stops the overproduction.
Exactly. The only time a patient really risks a hypoglycemic crash is if metformin is combined with other agents, like insulin or sulfonylureas, which are actively driving glucose out of the blood.
That makes perfect sense. There is also the perception that metformin primarily works by making peripheral muscles more sensitive to insulin. I hear that one a lot.
Right. And peripheral insulin sensitization in the muscle tissue does occur, and it does help the muscles take up glucose.
Okay, so it's not totally false.
No, but the data confirms this is very much a secondary effect. The dominant heavy lifting mechanism remains the suppression of hepatic glucose production in the liver.
Good to know. I was also looking at the FDA guidelines regarding kidney function. And this seems like the biggest misconception of them all.
Oh, the kidney debate, yeah.
Because for decades, the U.S. rigidly contraindicated metformin for anyone with even a mild reduction in kidney function.
They did. They relied on very rigid serum creatinine cutoffs. Because we know metformin is cleared by the kidneys, the regulatory fear was that impaired kidneys would fail to clear the drug, allowing it to accumulate in the bloodstream.
And trigger that dreaded lactic acidosis we discussed earlier from the fenformin days.
Exactly, the ghost of fenformin. It actually took until 2016 for the FDA to finally relax that labeling, safely allowing its use down to an estimated glomerular filtration rate, or eGFR, of 30.
And here's where it gets really interesting. The public perception on this is totally backwards.
It really is.
People hear about the kidney warnings, and they assume metformin actively damages the kidneys. But the drug doesn't hurt the kidneys. It just relies on them.
That's a crucial distinction.
Think of the kidneys as the trash collectors for this specific medication. If the trash collectors go on strike because of existing renal disease, the drug just piles up in the body's circulation.
Right.
And that pileup is what raises the risk of lactic acidosis. It's not attacking the kidney tissue itself.
Exactly. And by enforcing those overly strict kidney cutoffs for decades, regulators unnecessarily denied millions of diabetic patients the proven cardiovascular benefits of the drug.
Just out of an abundance of caution.
Yeah, they were prioritizing a misplaced fear of an incredibly rare side effect over the guaranteed daily protection the drug offered to otherwise stable patients.
Wow. Well, we've covered the history, the liver mechanism, the trials, and the safety profile. But everything we just outlined about the liver being the primary target, well, it might actually only be half the story.
Oh, yeah. There is a massive paradigm shift happening right now.
It's crazy. The pharmacology is turning into a genuine detective story because a significant portion of the scientific community is now debating whether metformin's primary fundamental site of action isn't the liver at all. They think it's the gut.
Which completely challenges 50 years of medical textbooks.
How do we even go from the liver's AMPK pathway to the intestines? That seems like a massive leap.
Well, it stems from studying tissue concentrations. When a patient takes oral metformin, the concentration of the drug in the tissues of the intestinal wall is exponentially higher than the concentration that ever reaches the bloodstream or the liver.
So the intestines are just practically soaking in it.
Exactly. And researchers are finding that it isn't just sitting there passively, it's actively altering the entire digestive environment.
What is it doing down there?
For one, it delays intestinal transit time, meaning food moves more slowly through the digestive tract. This naturally helps flatten out post-meal glucose spikes.
Oh, that makes sense.
It also fundamentally alters bile acid signaling, which plays a massive role in systemic metabolism and fat digestion.
But there's a hormonal component too, right?
Yes. It actually stimulates the intestinal secretion of a gut hormone called GLP-1.
Wait, GLP-1.
Yeah.
Listeners are probably going to immediately recognize that because GLP-1 is the exact hormone targeted by the massive new wave of blockbuster weight loss and diabetes injections.
Exactly right. Metformin essentially acts as a mild oral GLP-1 secretagogue.
That is mind-blowing.
It gets better. Beyond that, it actively reshapes the composition of the gut microbiome, altering the bacterial populations to favor those that produce beneficial short-chain fatty acids.
This completely changes how we have to view the drug. I mean, if metformin is systematically changing how our body processes gut hormones and reshapes our microbiome, it's not just treating a localized defect in the liver anymore.
No, it's acting as a systemic biological modifier.
Which perfectly explains why researchers are looking at it for applications far beyond diabetes. And that leads us directly to the TAME trial, targeting aging with metformin.
Ah, the TAME trial, yes. Championed by researchers like Nir Barzilai. It proposes a truly radical hypothesis.
Let's hear it.
They want to test metformin not for its glycemic control, but for its ability to fundamentally slow down human biological aging at a cellular level.
The idea that a 70-year-old diabetes pill could act as an anti-aging compound sounds like pure science fiction. Where does the foundation for this even come from?
It originates from a really fascinating paradox in observational data. Epidemiologists reviewing huge population data sets noticed something strange. Some type 2 diabetics taking metformin were actually exhibiting lower rates of cancer, cognitive decline, and cardiovascular disease than non-diabetics who are not taking the drug.
Wait, the weight of that sink in for a second. Individuals suffering from a chronic metabolic disease were, by several metrics, outliving healthy non-diabetic individuals.
That is what the observational data suggested, yes.
That immediately begs the question of mechanism. If it actually is slowing aging, how on earth is it doing it?
Well, the prevailing theory connects right back to its systemic effects. By activating AMPK and modulating the gut, metformin reduces systemic inflammation, which is often called inflammaging in gerontology, and that drives many age-related diseases.
Okay, so dropping inflammation.
Right. It also appears to mitigate cellular senescence, which is when aging cells stop dividing but refuse to die.
Zombie cells.
Exactly, toxic zombie cells. They linger and emit inflammatory signals, and metformin seems to suppress this toxic signaling.
That sounds incredible, but we really have to look critically at the observational data here, because comparing diabetics on a specific medication to healthy non-diabetics introduces a tangled mess of confounding variables.
Oh, the confounding factors are immense, which is why the theory is still highly controversial.
Right. I mean, Diabetics on medication interact with the healthcare system way more frequently.
Exactly. They may receive earlier cancer screenings just because they see their doctor more often. They're also frequently on other protective medications like statins or blood pressure drugs.
So disentangling the pure, isolated biological effect of just the metformin from the overall healthcare environment of a diabetic patient must be incredibly difficult.
It's nearly impossible observationally, and that is exactly why a rigorous, double-blind placebo trial like TAME is theoretically necessary to actually find the truth.
Well, regardless of how the anti-aging data shakes out in the end, the fact that metformin sits at the absolute intersection of metabolism, diabetes, and gerontology is incredible. Let's synthesize everything we've uncovered today for you.
Sounds good.
We established that metformin lowers blood sugar by basically acting as a governor on the liver's mitochondria. It triggers AMPK to shut down unwanted glucose production.
Right. And we also revealed the emerging evidence that it acts extensively in the gut, altering microbiome composition and hormone secretion. We traced its survival through a massive public health scandal, shielded by its clean, predictable clearance through the kidneys.
And we highlighted the clinical trials, like the UK-PDS, that proved it isn't just a cosmetic number fixer. It is a cardioprotective intervention that literally revolutionized the standard of metabolic care.
The global relevance for you really cannot be overstated here. Type 2 diabetes affects hundreds of millions of people, scaling directly with global obesity rates. And we are armed with a medication that is remarkably inexpensive.
It's frequently available as a generic for just a few dollars a month, right?
Literally pennies a day in some places. It holds a permanent place on the World Health Organization's list of essential medicines, and its clinical utility is now expanding to manage conditions like polycystic ovary syndrome, or PCOS, and prediabetes. It represents immense, highly accessible public health leverage.
It truly is the ultimate old drug, new tricks narrative. I mean, it evolved from a European folk remedy to a chemically misunderstood outcast to a life-saving staple, and now potentially a window into longevity itself.
It's an incredible journey.
Which leaves me with one final thought I want you to mull over after you finish listening to this deep dive. If a 1920s chemical derived from a medieval hedgerow weed genuinely holds the cellular key to slowing human biological aging, what other ancient remedies are sitting right now on our pharmacy shelves, completely misunderstood, just waiting for us to figure out how they actually work?